Good evening, everyone. Today I'm going to be talking about oral fluorescein angiogram. So let's start with a little bit. Let's try and compare these two images. I'm not trying to ask you what findings there are there. Let's just compare them in terms of quality and if the vessels are delineated and the contrast. Is there a stark difference between the right and the left?
Both are the same phase, right? Late phase.
So yeah, he could point out really accurately immediately. To have an accurate result is not possible because these are two different eyes in two different phases and at two different times. But so you'd basically be comparing apples with oranges if you were to answer the question. But what this goes to say is that the left image is comparable in terms of quality. You can grade it as well. So the right one is the IV fluorescein angiogram, and the left one is the oral fluorescein angiogram. So Simon Sinek was the guy who introduced me to this golden circle, which is to say that if you were to speak and try to lead, you must answer these three questions: what, how, and why. So in the next few slides, I'll try to answer these questions, and let's see where we are. So why do we need oral FFA? Because it is a safe modality. Its safety and efficacy was studied by Hara et al. In a large cohort. It is efficient and it is non-invasive. They studied 178 patients with 2,625 eyes, and they found that the photographs were adequate for clinical use for identifying leakage points, avascular areas, vessel staining, pooling in around 93% of the patients. They also found that the side effects were very low at around 1.7%, which were also of the mild spectrum, mainly nausea and irritation and gastric upset, which is at a lower range when compared to the intravenous fluorescein angiogram. So, what we need to understand is this is not something new. It has been there for quite some time, but it wasn't being used extensively because the image qualities that images that of qualities that we were obtaining with the FF450 or the digital angiogram or the flood photography were not as good, and hence, but now with the advent of better technology, confocal scanning, laser ophthalmoscopy, things are different. So there are studies that have compared the oral FA on a scanning laser ophthalmoscope versus the IV FA on the digital fundus, and they found this Claudio and Garcia et al. Found that the retinal pathologies could be adequately visualized to allow diagnosis and treatment in 82% of the cases. As time went passed by, the methods were improved by Manuel et al. This study uh, looked into various factors that affected the quality of the oral angiogram, and they found that fasting basically improved the quality, and also reduced the imaging times when compared to non-fasting state. This is because when one is fasting, the pH or gastric pH is a lot lower, and hence non-dissociated fluorescein is available, which is absorbed faster and better. Subsequently, many articles came out which compared oral fluorescein angiogram on the confocal versus the IV fluorescein in various retinal pathologies like diabetes and in CNVMs also. And recently, there is a comparison between the two in ROP patients. And it has been studied in pediatric retinal disorders as well. So, what is oral FA? It is nothing but a study of retinal and choroidal circulation with the use of dye administered per orally instead of intravenous injection. So that brings us to how is it done. You need a certain prerequisites, which is basically consent. You need to have an emergency response team ready, even though the adverse effect rate is really low. You need to have adequate dilatation, and fasting for 2 hours is recommended. Confocal is preferable, though it can be performed with digital as well. So if the age is less than 18, you take 1 ml of 20% fluorescein, you add, which basically contains 200 milligram. You add 4 ml of distilled water. So 1 milligram contains around 40 milligram. So the dose is 7.5 per kg, 7.5 milligram per kg for pediatric age group. So if a child is around 16 kgs, then you would basically do the simple math 16 into 7.5, that would give you 120 milligram, and then you divide it by 40, so you get 3 ml. So you take this 3 ml and you mix it with a sugary drink and you administer the drink. It's preferable to drink this in one gulp. Then you start the image acquisition after 4 to 10 minutes of ingestion, and it continues until 30 minutes. And monitoring is done. One must remain on the site for 1 hour after the dose was administered to monitor for any adverse effects. Similar thing for adults. The dose required is around 1 gram. So here it's a lot easier. You just take 1 ml of 20% fluorescein, and you just take 5 ml of that solution actually. So the image acquisition and monitoring is the same. So where is it indicated? It is indicated in children and in cases where IV access is difficult. It can also be used where IV access requires special precaution and increases the risk, such as in cases of infections like AIDS and STDs and viral hepatitis. So if it is so beneficial, then why not every case? Because it does not capture early images. The phases that are described in the IV angiogram are not so well delineated on the oral, and this method is unreliable in visualizing the FAZ. It cannot investigate foveal ischemia, particularly if there is macular edema, and in the presence of NVD or NVE, there is profuse leakage, and so CNP areas cannot be identified very clearly. But without the presence of these neovascular complexes, even CNP areas can be picked up. So the advantages are that it is safe, non-invasive, and simple, and it can avoid the need of a prophylactic injection of steroid, because only 1.7% of the cases had an adverse effect. And this is quoted in the study that I mentioned before. The disadvantage is that the early phase is not captured, and around 2.7% of the patients require another study, because that's the failure rate of uh, the intervention, and it is also more time consuming. So this brings us to my case. A 9-year-old male came to our OPD, was referred by a local ophthalmologist for evaluation of some retinal disorder. His birth history was normal milestones, vaccinations were up to date, and the vision in both the eyes was 6, 9, and 6. Anterior segments were, and external examination was unremarkable. And this is the fundus photograph uh, of the right and the left eye. Right eye uh, looks predominantly normal, and left eye you can see hard exudates in the macular region and some vascular abnormalities in the temporal quadrant. Uh, a red-free image of the same. Again, the vascular abnormalities are much better delineated here. And he underwent oral fluorescein angiogram. This is the angiogram of the right eye. You can see that the phase is already late by the time the image has been captured. And this is the left eye. In the left eye, predominantly, you can see some level of uh, leakage near the macular area, a lot of telangiectatic vessels, these light bulb aneurysms, and shunting is also present. Also, you can note the peripheral non-perfusion area. So he was diagnosed with codes and was advised laser to the peripheral CNP areas. Our second case is a 49-year-old female was referred to us by a local ophthalmologist, again for evaluation of diabetic retinopathy this time. Diabetes since 6 years, vision both eyes 6, and 6, anterior segment predominantly unremarkable. So the fundus photo of the right and the left eye. Right eye, you can see there are a few hemorrhages, and he had features basically of moderate non-proliferative diabetic retinopathy. Left eye also had these uh, dense asteroid eye losses, and so we wanted to rule out presence of PDR, and so he was advised FFA. And you can see the images on the right and the left. What's special about this case is that the patient underwent the FA on both the spectralis and the FF450. On the right hand side, you see the spectralis image. You can clearly delineate the MAs, and the vasculature is also well defined. Uh, and on the right side also, you can see these MAs. With a little playing of the contrast, you can pretty much visualize a lot of things there also. It's also unfair to compare, because again, the one on the right is on the taken after the angiogram was completed, So it is a later phase. And again, in the left eye, this similar picture, you can see these leaky microaneurysms in the superotemporal quadrant, some non-perfusion area inferiorly. But other than that, both the digital and the spectralis did capture. More to say that the contrast was much better in the spectralis. Diagnosed with NPDR with non-center involving DME. So my take-home message is oral FA is a good modality, though it does not completely replace IV FA. It may be considered in cases where IV access is difficult and is of much use in pediatric population. I thank you for your patient listening. Uh, and this is obviously a team effort. I thank Dr. Aran, Dr. CR, and Dr. ABK for helping me out.